Welcome to Rwenzori Focus on LC Africa, the content factory. This evening, I host Dr. Chris Baryomunsi, the Minister of Health, who has just gotten into office about 3 months ago after being appointed by the President of the Republic of Uganda, His Excellency Yoweri Kaguta Museveni. Congratulations, Honorable.
Thank you very much.
I've not had
greetings to all viewers.
Opportunity to have a discussion with you after your appointment.
Yes.
You know, you are used to media, ICT.
And you're always very welcome.
You're now at Minister of Health.
Yes.
How have you found the environment here?
The environment is okay because I was here before as a Minister of State for Health. And I toured it through Ministry of Lands, Ministry of ICT. Now I am back to the Ministry of Health, and being a professional medical doctor, this is my parent ministry. So I have not been very far from the Ministry of Health, and therefore I have settled in fairly well. Yes.
Well, we are hosting Honorable Chris Baryomunsi, doctor. He doubles to be a PhD holder and also a medical doctor. We are discussing issues pertaining the medical interns. Honorable, you come into this ministry at a time when it is facing a number of difficult questions. One of them being the medical interns and their welfare. And today, when you had your statement at the floor of Parliament, some people still believe that you need to make a further pronouncement on how the government is ready to take on the issues of the medical interns.
Well, yes. Let me first explain who are medical interns. You see, in the discipline of medicine, students train for 5 years at the university to qualify as medical doctors. There are also other disciplines like Bachelor of Science in Nursing, there are graduate nurses, there are also pharmacists who also train and graduate as a pharmacists. Now, they graduate from university, but before you get a practicing license to start practicing your profession, you are required to undertake a 1-year apprenticeship or internship, meaning you are deployed in a hospital which has specialists.
Does it have to be a government hospital?
No.
Or even private hospital?
Even private hospitals.
Okay.
But particularly the private not-for-profit hospitals. These hospitals which are faith-based, like the Zambia Hospital, Rubaga Hospital, because they have specialists, we also deploy these interns there. So you are deployed in a hospital which has specialists, the consultants, so that you perfect your skills as a doctor, the clinical skills, under the supervision and oversight by the senior doctors. Then after 1 year, if they are satisfied that you can now be a doctor and practice on your own, then they release you, you pass. So internship is examinable. You can fail internship and you repeat it.
Oh,
so if yes,
it's examinable.
Yes. Examinable in the sense not that you sit exams, but the supervisors,
they look at
the consultants,
at your conduct.
They assess you. They assess you and say, yes, from the way this intern has performed in the last 1 year, we are now confident and comfortable that he can be released and he can be a doctor and practice on his own without any supervision and such. So that's what we call internship. So it's a transition between being a student and being a fully licensed medical practitioner. So when we deploy these interns, they do work. They provide labor as they learn. They provide labor under the supervision of the seniors. Now, when I qualified as a medical doctor years back.
How many years back?
This is over 30 years.
Okay.
Because I qualified in 1995.
Well,
that time we had only 2 medical schools, Makerere University and Mbarara
University of Science and Technology.
Yes. But today, And we were few doctors who were coming out of the universities. But today we have over 10 universities, both public and private, training medical doctors. So the numbers have become big, and this has had a budgetary implication. So we've been facilitating intern doctors when they are working, and currently we pay them 1.2 million Uganda shillings. When it is taxed, they get a net pay of 1 million.
All medical interns?
Yes, all the medical interns.
Okay.
But last year, government passed a new policy on health training, which touched on issue of internship. So there are proposed changes in this new policy. For instance, the policy proposes...
The policy has been passed by parliament or
by cabinet?
By cabinet.
Cabinet, yes.
Okay.
It's cabinet which passes
policies.
And can just be deposited in the parliament.
Okay.
Now, in the new policy, there was the issue of facilitation or the allowance being paid to the interns. Now, because of the huge numbers of interns, there was a question on whether government can afford to pay these increasing numbers. So a proposal was brought and passed that internship be considered as a continuation of the training of a medical student or a pharmacist or nursing student. To that extent, we have two categories of students.
Okay.
There are those who are on government sponsorship, and there are those who are privately sponsored. So the new idea was, let the government continue sponsoring those who are under government sponsorship in the university. Meaning, when you start your internship, then the intern will continue receiving the 1 million Uganda shillings from government, as it has been. Then for those who have been privately sponsored, then your sponsor should continue catering for you, but the government should provide you with meals, because you are on duty in a hospital, should give you meals for you to complete the internship.
So what was the computation of the meals for these privately sponsored?
When the ministry computed the cost for the meals, it came to like 500,000, about 500,000.
That is 500,000.
Yes. So the contestation which is there and what is causing discomfort among these pre-intern medical graduates is that they wouldn't want this discrimination. So they should be treated the same, whether you've been the government sponsored or privately sponsored.
Honorable Minister,
so that's where the standoff, if I can.
When the ministry computes meals, does it consider only more breakfast, lunch, and supper, or specifically they just think about lunch only? Because
all the meals.
All the meals. So for the entire month, 500,000.
Yes.
Okay.
Using government rates, because they are standard government rates, which are used to compute these figures. Yes. So that's what has caused the discomfort among these medical graduates. But we are carrying out consultations with a view with whether we can have a meeting of minds.
Did the government's position arise from the fact that since these students can manage paying for themselves in private institutions, they are given a stipend of 500 so that they can, if it is not enough, see how they can mitigate through?
That's part of the reasoning. And because the numbers are growing, it may not be sustainable, keep them at that rate. And then the argument was also that if been able, because there is a university, where students pay $3,000 per semester, that's around 11, 12 million shillings. There is another one where students pay 7 million shillings. So part of the argument was, if you've been able to pay over 10 million shillings a semester for your university education, why shouldn't it be possible to cater for yourself for 1 year to do internship and you get the professional practicing license? Those were the arguments. So But either way, we shall have it.
So Honorable, what is the current government position on interns?
The current government position on interns is as I have
explained.
That yes, when you qualify and complete your university education, you proceed and get deployed for internship. That's the position. But the change is just on welfare.
Does government ever think about the growing number of medical practitioners going through university and see a way of how to plan for them? Because government is not aware actually of how many are out there graduating from universities.
Actually, there has been a process to guide the medical schools, and they have been given quotas on how many medical students
can be enrolled.
Can enroll, yes. But I think some of the universities have been defiant, and they don't follow the guidance of the National Council for Higher Education. And going forward, we are going to sit and regulate admissions. Because you see, training medical students is not like training other professions, with due respect. Even, say, Makerere University, which is an old university training doctors, they always have small numbers, because a medical doctor, to come out of the university, you must be very sure that this doctor is competent, this doctor is thorough, he has been trained, and you can be confident when you go through his hands. That is why, for instance, medical degrees are not graded. First class, second class, no. You will not see that this one has a pass degree.
A degree is a degree.
A degree is a degree. Because if you came as a patient and they tell you that the doctor got a pass degree, probably you would doubt his competence. The people will be running for one who got a first class,
that's
thinking
true.
Maybe he's the best doctor. But in the wisdom of medicine as a discipline, the degrees are not classified. Now, what that policy which has been passed is trying to address also is to see that there are standards which are set. So that a doctor who qualifies from Makerere University should be equally competent like the doctor qualifying from Kampala International University, King Caesar University, Guru University, Busitema. They should be comparable in terms of quality and competence. So the standard.
So, Honorable, the opposition says for the past few months, they say that government is being helped by these interns, that you do not have enough workforce in hospitals, and that if they lay down their tools, there will be a standstill of services in government hospitals. As Minister of Health, would you be bothered by the industrial action that can be taken by the interns?
Well, these interns are our sons and daughters. And we would want them to do internship, qualify, get their practicing licenses, and they join the family of doctors. And they should appreciate that one. The challenge is notwithstanding. It is not true that the health care in Uganda is delivered largely by intern doctors. Yes, they make a contribution because as they train under the supervision of the seniors, they are also providing labor, providing a service to the patients, because they learn in the medical training, you learn by practicing on the patient, and more so at the level of internship. So, I am not trying to discount their contribution. They do make a contribution. But the argument that they are the ones who run the hospitals, and therefore their absence will cripple service delivery is not necessarily true.
Maybe, Honorable, you can bring in the figures. What is your current staffing percentage of the general hospitals and hospitals where these doctors are being deployed?
Revised staffing norm for health facilities, and you have had people running around with the low percentages. those are calculated on the basis of the new staffing norms which have been approved by the ministry and by government. For instance, a health center for initially had the provision of 39 health workers. We have since revised that norm and expanded it to 150. So when you compute the current staffing and you use the new staffing norm as a denominator, then the percentage becomes low. But if you use the old staffing norm, then the percentages in many places are above 50%. But when you use the new staffing norm, and we have not started recruiting basing on the new staffing norms. For instance, the health center for the initial staffing norms were to have 2 medical officers, 2 doctors. But the new arrangement, they are supposed to be 4. So this new arrangement, we have not yet started recruiting for that. So the figures depend on which denominator you are using.
Okay, Honorable.
The staffing level in most of the facilities ranges from 40 to 50% thereabout. But definitely, we would want in the next 5 years to really increase that percentage to 70, 80%, if not 100.
Honorable, we train doctors, nurses, pharmacists, and other health professionals. But then many of them struggle to find opportunities, with public health facilities continuing to report shortages. Where is the disconnect?
The disconnect, yes.
We are getting a huge number of graduates, but they are not getting opportunities. And in some instances, some of them even go outside the country. And yet the country needs their services.
Yes, like I said, because of the liberalization in education space, there are now many universities training medical graduates, doctors and other professionals. And probably from the planning perspective, there has been a disconnect between manpower planning and the pre-service training at the university level, which we are going to look at.
To bridge the gap.
So that we estimate how many health workers we need, and that should inform the kind of admissions that the universities undertake, so that there is a connection. The other issue is that we now run a decentralized service, where service delivery at the level of a general hospital, that's a district hospital, health center 4, health center 3 sub-county and lower levels, is in the hands of local governments. Those are the ones who have to advertise, recruit, and for us as a ministry, our duty is mainly to set standards and manage the other hospitals at the national referral and regional referral. So with the decentralization, it's now the district service commissioners that recruit now. And the numbers are restricted.
The service commission recruits doctors for districts.
For districts,
district
yes.
hospitals.
And like I said earlier on, the staffing norms have been constricted, where you find maybe a district has 2 constituencies, therefore 2 health center 4s, and will be putting a provision of 2 doctors per health center 4. So you find a district probably has a provision to have only 4 doctors, but the universities are churning out very many graduates. So you find there are many doctors who are on the street. They qualify, they do internship, they get registered, but they cannot be absorbed in the civil service because the numbers are big.
So that means
Yes.
we are training more health professionals than the government can absorb.
So at the moment. So what we've done as a government...
Or we are simply not recruiting enough.
Yes, because of budgetary issues. But the decision has been...
Have you put this at the knowledge of the president?
Yes, not only the president, but we have discussed it in the cabinet, taken a decision, for instance, to recruit and deploy doctors to as low as the health center 3 as a sub-county level. But also as a ministry, we are studying the idea of training for export. I know many Ugandans will be uncomfortable with it and say, we don't have enough doctors. How do you look at exporting?
At one time, we wanted to import doctors from Cuba, if you can remember,
exactly.
some 15 years ago.
Yes, so we are also studying that. Because there are countries in the Western world where they have a shortage of medical workers. And we are trying to engage some of them to say, if country X needs doctors, and here we can't absorb all the doctors in the civil service, why can't we make government-to-government arrangements, and we send some of these doctors to provide a service in those countries? We are exploring. We are still at the infancy stage of discussing this. But also, we are examining the policies with a view of creating incentives for health workers, particularly doctors, who would want to go into private practice. Because understandably, not every medical worker will be absorbed by government. So we need to create a favorable, conducive, and supportive environment that enables these doctors
To work
if they
even
want
when
to
they're not in
establish
government.
private facilities. For instance, if 5 to 10 doctors come together and they say we want to put a hospital, especially in the hard to reach areas, Karamoja, Kasese, those hard to reach areas where there are no good services, then we want to see what kind of incentives can we provide. Can we, for instance, have cheap money which these doctors can access and put a facility and pay through a long-term financing arrangement? Can we waive off some of the taxes which would be prohibitive, and so forth and so forth? We're also studying this because it is painful to see doctors train for those many years, do internship,
And
then
then
at the end of the day,
leave the country.
not only leave the country, but they are jobless. They are jobless.
Do you have any doctors that are jobless?
Oh, yes.
I rarely meet doctors that are jobless.
Well, they are there. There's a doctor who came in my room, in this office.
And he is jobless.
And he asked me, Honorable Minister, I passed agriculture at all level. I got a distinction. So I believe I have some skills in agriculture. Can you employ me as your farm manager? Because I suspect you must be having a farm somewhere. And I said, why? You trained as a doctor. I said, I can't find employment. So there is also that crisis that the doctors now complete university, complete internship, they get their practicing licenses, and they are floating.
There is still a huge question that lingers on the Ugandans' mind. That why doesn't the Ministry of Health get the lion's share of the Uganda's budget?
Well, I don't know whether I'm the best fit person to answer that.
Yes, you should, because you have been in government for more than 30 years. So who should respond?
30 years.
Honorable, you have been the chief government spokesperson for 5 years. You have been speaking for government.
Yes.
You have been in cabinet for more than 20 years now.
No, 10 years. Just 10.
10 years.
I became a government minister in 2015.
So it is 10 years. 10, 11 years.
10, 11.
Well,
that's good enough.
That's good enough. Now, why doesn't the Ministry of Health get the lion's share?
In 2001, governments in Africa meeting in Abuja, Nigeria, committed that governments should allocate at least 15% of their domestic budget
to health.
Domestic meaning the national budget excluding donor
funding.
15% to the health sector. Few, if any, governments in Africa have been able to meet that target. The last time I checked some years back, up to 6 countries had got that target. The highest we have gone in this country is 11%. But then we've been oscillating between 6 and 11. I think currently around 6%. So we've not been able to hit that target, which would be the ideal. Of course, the issue is the competing national priorities. Yes, health is a priority, but also there are other areas which consume a big part of the budget. Security and defense, given the volatile environment in which we live, the investment in infrastructure.
Ugandans say we have been having peace for more than 20 years. Why should the security take the lion's share?
But that peace is not just abundant anyhow. We invest in that peace to be there, that security. You see, we are surrounded by countries which are at high risk of volatility and insecurity, DRC, South Sudan, and others. So, you have seen the government deploy our UPDF, Somalia, South Sudan, to DRC, Central African Republic. We spend. So, this peace, you see, the stability, the security we enjoy within the country, there are investments which the government makes in order for us to keep safe, to keep secure. If you look at the investments the government has made in infrastructure, the roads, electricity, and so forth, but also when you are reflecting on how much we spend on the health sector, you should keep in mind what we call the social determinants of health. When we invest in roads, that also is contributing to better health in the country. Because if you talk of a referral system, the ambulance system, if you have poor roads, which are non-motorable, then you can't refer these mothers for better health care. If you don't have electricity, for instance, the functionality of the hospitals, the theaters gets compromised. So there are areas which are not directly under health, which we fund, but they contribute to the attainment of better health. So we must also look at it from that context. The investments we make in water and sanitation, water and environment, those also contribute to better health.
Maybe the ministry is comfortable with the donations because amongst all the ministries, Ministry of Health is the topmost ministry that gets most donations from foreign aid.
Well, yes, we appreciate the support, technical and financial, that we receive from partners, but in the long term, we must address the question of sustainable financing, which means we should allocate more resources from our own budget, because donor funds are not reliable, are not sustainable, and sometimes these partners come with their own interests. They may not necessarily prioritize the interests of government. They may have their own priorities. Yes, while we appreciate that funding, but sustainably, we must put money as a government to finance health.
Well, away from that, you know, you have come into this ministry and found a lot on your table. You found Ebola on your table.
Yes.
You found a disaster that you managed to contain. How did you manage to contain this outbreak, even when the Western media tries to downplay the effort that Uganda is trying to put in, and also try to downplay that the number of days that you had issued to count the 42 days are not yet done?
Yes, Ebola is a viral hemorrhagic fever that we have handled for a number of years. The outbreak, which we announced in May this year, was the 9th outbreak. The first one having been in 2000. Its origin is the DRC, Congo, where they witnessed the first case in 1976, as well as Sudan, South Sudan. There was a simultaneous outbreak in the DRC and South Sudan in 1976. And since then, there have been many outbreaks and flare-ups in Africa. So it's an African disease.
What causes Ebola?
Ebola is a viral disease. It's caused by a virus called Ebola virus, or Ebola filovirus, if you want me to be too medical. And it was first identified in Congo, in the communities around the river Ebola. So Ebola is a name in the DRC.
So there is a river in Congo called the river Ebola.
River Ebola. And the first cases of Ebola disease occurred in the communities around that river. That's why it was named Ebola. This Ebola virus ordinarily is resident in the bats, fruit bats. Bats, but also it can be resident in non-human primates, monkeys, chimpanzees. That's where the virus usually resides, but doesn't cause illness in that animal, especially bats.
Okay.
Now, when there is a crossover from what we call a reservoir, from a bat to a human being, then it causes a disease in the human being. In the medical
Doesn't that come after one eating that?
In medical terms, we call that kind of a disease a zoonosis. So if you come across a term that is a zoonotic disease, it means the organism that causes the disease is resident in an animal, like a bat,
but
like
cannot
a monkey,
harm it.
Cannot harm it. But when it crosses over and enters a human being, it causes a disease.
Okay.
And it enters through eating raw meat or poorly cooked meat. Or butchering, when you are butchering a monkey or any other animal or this bat. Even from products of bats like droppings of even the monkeys. So that interaction between the human being and that animal reservoir is what facilitates the virus to move from that animal to a human being.
Now I understand.
That's how Ebola comes.
Now I understand.
And there are different strains of Ebola.
The one we had was called Ebola Bundibujo.
The one which has been hitting Uganda and DRC is Ebola Bundibujo. Why Bundibujo? That type of Ebola virus was first identified in 2007 when we had an outbreak in the Bundibujo district in Uganda.
I remember that outbreak.
So it gets the name from Bundibujo. Now, we declared an outbreak of Ebola in May this year, 2026, to be exact on the 15th of May, and we managed the cases. We registered 20 positive cases, and they were treated. 2 died, 2 Congolese nationals who had come into Uganda, unfortunately died. May their souls rest in peace. This Ebola outbreak originates from DRC, and as we speak now, they have so far confirmed over 4,000 cases of positive cases of Ebola, and they have lost over 2,000 Congolese
in Congo.
And the infections are still moving up. So in Uganda, why we managed to contain this outbreak is that when we found out that we had the case of Ebola, we made announcements and activated the national response. And particularly we mobilized the communities along the border with the DRC because this was an imported outbreak. We sensitized the population around the border areas. We instituted public health measures like closing markets, like disallowing gatherings like weddings. In some of the areas, even the church gatherings were stopped. Sensitize people, used the radios and other media platforms to sensitize people, and the people on the alert. We closed the border points, the points of entry. We closed them. We even deployed security to man the border and see those who may want to use the porous border points, so that the Congolese who were suffering from this challenge
do not run away and cross to Uganda.
We even entered a memorandum of understanding which included Uganda government going to establish treatment centers in Congo, so that the Congolese...
At whose expense, Honorable?
At the expense of Uganda government and partners. We have so far sent 58 experts from the government of Uganda, Ministry of Health, to go and supplement efforts of the Congolese brothers and sisters, and many other cross-border activities which we are carrying out together with Congo. So because of the heightened vigilance and activation of the national response, strengthening surveillance, risk communication, having strong laboratory services, but also having built capacity over the years because of the past epidemics like Ebola and COVID. We had a strong surveillance system, strong laboratory system. We managed, and also a population which was vigilant, and also with the leadership of the president, we were able to contain this outbreak. You recall, for instance, the president guided that we put off the celebrations of Uganda Matters in Namugongo, which is a huge event.
Which had so many people.
And by the time we
had the tourism people,
there were over 600 Congolese nationals who were already trekking into Uganda. Now, if we had allowed that event to take place, that would have been what we call a super spreader event. And probably today, the story would be different in Uganda. Probably the Ebola would have spread to all the corners. So it was this heightened vigilance and strong capacity,
political leadership
of the government here that we managed to contain.
Honorable, have you had voices of Ugandans who say that you always bring these outbreaks in order to siphon money from donors?
As I answer that one,
have you heard it?
Yes,
have you heard about it?
So the issue of announcing the end of the outbreak was based on the science.
Okay.
You see, the science is that when you discharge the last patient, then you get an assumption that this patient could have exposed some people. And therefore you give time for, if there was anybody who was exposed, you give them 2 rounds of incubation period of Ebola. Incubation means if the Ebola virus enters my body, how long will it take to express itself through symptoms? That we call incubation. And the incubation period for Ebola is between
in simpler terms, you can call it the germination period.
Germination, from 2 to 21 days. So we usually count 2 rounds of that germination you are talking about, the incubation which period gives it 42 days. Now, in the case of the outbreak that we had in Uganda, I think what was causing confusion, that the last patient whom we discharged, if we had used that one, then the countdown would have taken us to 28th of August, which is a few days from now. But when we went back and examined the science, that patient left Congo in a cargo truck. He went into a cargo truck which had a driver and a turn boy, and hid in the cargo area. And when he reached Kampala, he made a phone call to the health authorities. I am so and so, I am from Congo, I am sick.
I need special care.
I need special care. So an ambulance was arranged and he was picked from the cargo truck and taken to the treatment center. So when we examined, we found this patient did not expose anybody to Ebola. And therefore we discounted him and used the second last patient to be discharged. That's how the days came nearer. So it was guided by science, not merely declaring, because yes, you say last patient, but on the assumption that that last patient could have exposed some people. So this last one had not.
So the declaration was based on science? On
science, yes. It's not guesswork. Because by the time I declared the end of the outbreak, I was sure that there is no active transmission of Ebola in Uganda. Because you see, in the management of Ebola, when somebody tests positive, then you work backwards and trace all those contacts who were in touch with him in the last 21 days. And for the 20 cases we registered, we were able to trace all those contacts and looked after them. They completed 21 days without developing symptoms, and we discharged them. So by the time I announced as the Minister of Health that we are marking the end of the outbreak, I was sure in the corners of the country, within the country, there was nobody who could be harboring a virus of Ebola.
Now to my question. Have you had silent voices?
Oh, yes.
That you announce outbreaks in Uganda to get money out of the donors? Specifically organizations like WHO and others?
I think those ones you should ask them a question before I answer. That have Ugandans died of these epidemics?
Sometimes, yes.
Yes. It is not true.
But this time, Ebola, we didn't have any person who died from Uganda.
There are 2, but they were Congolese.
They were Congolese, I'm saying from Uganda.
No, from Uganda.
Ugandans.
Because of the 20, only 5 were Ugandans. 4,
and they recovered.
4 were health workers who treated, especially the first case, because they didn't know it was Ebola. And the fifth one was a driver who transported one of the Congolese nationals.
Okay.
So we didn't lose, fortunately, in Uganda. It is not true that it is money that motivates the Ministry of Health or government to announce epidemics or outbreaks, because that would be unethical and illogical. We announce these outbreaks because the international health regulations, the guidelines from WHO, classify diseases differently. There are diseases like Ebola. Even if you get only one case, then that one becomes an outbreak. We are duty bound by these international guidelines to notify WHO and announce the country. So for us, we run a transparent system. Probably there could be countries which
that
just
can
keep
conceal.
closed. Even when they register these epidemics, these outbreaks, they keep quiet. That's their own policy. But for us, you see, we value life. I know there has been a concern that when we announced Ebola, then there have been travel restrictions which have been instituted and imposed by some countries. We have lost out on tourism. But for us, from Ministry of Health, we think life is primary. We are like Jesus. Jesus in Matthew chapter 6, verse 33, he said, "Seek ye first the kingdom of God and his righteousness, and then the rest shall be added unto you." So even as the Ministry of Health, we say,
You go to church, I have seen you're a believer.
So in the health, we say, protect the lives of Ugandans first. Once they are disease-free and healthy.
Let us go into a short commercial break and we shall be right back.
Mu mutima gwa Uganda mulimu ekimera eky'enjawulo era nga kigiddwamu omutindo ogusukkulumye. Eŋŋano ya jiko nga ekolebwa ab'amaganjo grain millers. Kola ebyokulya eby'omulembe nga okozesa jiko owoomerwe ne famiri yo ne ku mikolo gyo. Yimusa omutindo gw'enfumba yo oyimuse essanyu lyo nga okozesa eŋŋano ya jiko. Ekolebwa ab'amaganjo grain millers. Eŋŋano ya jiko evaamu ebyokulya ebiwooma nga byagalwa. Woomerwa akaseera konna nga okozesa eŋŋano ya jiko. Maganjo grain millers, feeding nations.
Welcome back from the commercial break. We have Honorable Chris Baryomunsi. Is it Crispus, Christopher? Why is it Chris?
Chris.
Just Chris. Now, Honorable, there is a concern from the tourism industry or the tourism sector that you have always mishandled the outbreak information and it affects them and affects their business. The other time I had an extensive interview with Amos Wekesa, who is the team lead for Rwenzori Marathon, and he said the pronouncement by Uganda that we had Ebola stopped internationals from UK, US, and other countries from attending the marathon. How well can you package the information so that it doesn't affect the tourism?
Yes, maybe he has a point that while we have a duty to communicate, we must also be mindful of the implications of how we package the communication. So we should communicate without scaring the world, but also without injuring the economy, so forth. But we still have that duty because life first, then the rest will be added. You see, the problem is not the communication that we made. The problem sometimes is just countries which have bias on us because we are in Africa. You see, when you look at the international health regulations, the guidelines from World Health Organization, there is no way it states that you should impose travel restrictions as a way of managing Ebola. No.
We are still listed under Tier 4 as Uganda.
Yes. So the reason guiding these countries that are imposing travel restrictions is not based on science and public health as we know it, but rather to the bias they have on Africa, to the fear. Let me give you an example or an explanation. Like I said, Ebola disease was first identified in 1976. Today is 2026. That means Ebola has been with us for 50 years. Now, here in Uganda this year, the outbreak we had this year was the 9th. The first one having been 2007, which 2000 in northern Uganda. You remember when we lost Dr. Rukia in the Ebola outbreak, northern Uganda. We have since had 9. In Congo, they are now battling with the 17th outbreak. Since 1976. There have been outbreaks and flare-ups in other parts of Africa, especially West Africa. In 2014-15, we had a huge outbreak in West Africa where 11,000 people died. Now, since 1976, we have had about 40 outbreaks and flare-ups in Africa of Ebola. 40. But if you look at exported Ebola cases that have gone out of Africa and are reported in the US, in Europe, and other parts of the world, they are less than 30 in 50 years. Actually, to be exact, if you include the recent case of France, they are 29. The one in France was the 29th. What does it mean? It means, given the transmission dynamics of Ebola disease, it does not easily spread overseas through commercial flights, through this international travel. Even in the 29 I'm talking about, when you look at them, it's mainly doctors and health workers who were managing these Ebola cases in Africa. Taken abroad for and they treatment. Get infected, they are taken abroad for treatment, for better care, most of those. So, Ebola disease is not like COVID.
So these countries have bias.
Yes, the Ebola disease is not like COVID, which spreads through air, and you can cough and infect a person. No. So that means the travel bans and restrictions imposed by these countries is not, like I've said, guided by science. They are uncalled for. And the question is, I said earlier on that even one case of Ebola constitutes an outbreak. There was this case of Ebola in France. Did they declare an outbreak in France? No. Why? Because France is in Europe and for us we are in Africa. And we've been engaging these countries that please be fair.
Actually, that was my next question. How are you going to engage these Western countries to see that at least you have a fair ground?
We've been engaging them. I have had meetings with the top officials of World Health Organization, of
CDC.
Africa CDC, and other agencies. But also bilaterally, we have engaged like the leadership of the embassy of the US here in Uganda, Canada, and other countries that please, these travel restrictions are not known as one of the public health measures to contain Ebola disease. People can still travel as long as the airlines and the airports and points of entry put in place SOPs, standard operating procedures, and public health measures. You can still contain Ebola without restricting people. Like now in Uganda, we do not have any active case of Ebola disease. Why are they still maintaining restrictions? There is no risk of contracting Ebola when you travel to Uganda. And interestingly, some of their citizens come here. He come and go. I hosted.
Yes, Wekesa tells me that the internationals that will still come even when they have told them not to come to this country.
But if you now travel from Uganda and go to their country, they will say no. They won't even give you a visa. So this discrimination and lack of respect for others, at times we receive it with contempt. That we are the same people, we are children of the same God, and therefore countries should not have bias on other countries. We should be guided by science and be fair to all.
So, Honorable,
but we are engaging with a view of persuading them to open up.
Next weekend on 22nd, Kasese will host the Rwenzori Marathon. And just like you said, Ebola is still ravaging the Western Congo. Eastern Congo, sorry.
Yes.
Eastern Congo, and Kasese being a border district with Congo. As Minister of Health, which measures have you put to see that people do not import
Yes.
the virus?
First of all,
the disease
we've
to-
allowed that marathon to take place, but requested the organizers to observe standard operating procedures and public health measures to ensure that we minimize or eliminate the risk of any transmission of Ebola disease or any other illness. And therefore, those traveling into the country will go through screening at the ports of entry, especially at the airport. But also we expect the organizers at the marathon to put measures like washing hands or sanitizing and the other measures as we have been announcing them. But also we shall have restriction for those who may travel from Congo because there is a high risk of Ebola in Congo.
They would go through quarantine.
If you travel from Congo, we shall put you
Quarantine for 21 days.
21 days.
So that they would miss the marathon.
But we don't even have 21 days between now and the marathon. So it should have come earlier so that you go through that isolation. But probably there will not be many participants coming from DRC because we suspended the flights to DRC. We also closed the points of entry.
So the border to Kasindi through Kasese is still closed?
It's closed, but we allow goods, business goods can cross, and but with a driver and the so there is no possibility that a person can come from DR Congo to Uganda.
It's
naturally and illegally come, but but we shall subject him to those measures. So the trucks carrying merchandise, trade, business goods are allowed to cross. Humanitarian actors can also cross. The military and armed personnel who are keeping peace and security, they can also, but they go through very rigorous screening at the border points. So, and all of this, the viewers, because we have received complaints from people who have been running markets and the cross-border trade, they are done in good faith. These are disease prevention measures because yes, you may claim for opening the border and opening markets, but people may die, and once a life is lost, it is lost. So it may be painful suspending some of the business which has been sustaining the people there, but I want people to understand that the English say to get an omelette, you must break an egg. So for us to have an Ebola-free environment and avoid these diseases and deaths, we may have to suffer sometimes. But so be patient, especially as we help our brothers and sisters in Congo to contain the outbreak. We are going to discuss as a national task force to see how we can soften on some of the measures which we had imposed in those communities along the borders.
Well, as we come to the close of this program, this show, I always host Honorable Chibanzanga Christopher. You know him?
Yeah, I know him, yes.
He has raised
the MP for
Bugandera, and he's the prince in the of Singapore and Zulu. He has raised concerns from his constituency that the health status of the health centers in Rwenzori and to be particular in Wundiwujo district are in sorry state. As you are moving around to monitor and make impromptu visits across the country, would you have Rwenzori sub-region in your plan to see the status of the health?
Absolutely. I worked in the Rwenzori sub-region. I worked in the port of the GTZ, and I was covering the greater Tora and Rwenzori, covering Wundiwujo, Toroko, those areas of Kasese. and therefore it's one of my favorite regions, which shaped me, which is responsible for my professional growth, and which contributed largely to what I am today. So it's my area, and definitely I will pay a visit and look at those health facilities, both in the Toro region, but also the Rwenzori, ranging from Kasese to Bundibujo, Toroko. We have a plan in the Ministry of Health to address those challenges, like challenges of infrastructure. You find some hospital, like Bundibujo Hospital, is an old hospital which requires renovation and comprehensive overhaul and facelift, and even the lower level health centers. Yes, I will visit, and the budget permitting, we shall be able to handle and address those challenges.
Honorable,
and other areas of ensuring their medicines and other supplies. So I will be there. I will be there, and I will link with Honorable Chibazanga and the other members of parliament to be part of that effort to look at the health facilities and then support them.
there is a presidential directive that the Ministry of Health should give special attention to hard to reach areas. What intervention is the ministry having for these areas?
Yes, generally there is a standing policy that in hard to reach areas, the public servants receive a hard to reach allowance. And actually they do. They receive
Incentive.
An allowance over and above what other civil servants get. But also in terms of health, the standing policy is that every sub-county should have a health center 3. We had earlier on started constructing health center 2s at parish level, but that policy was put on hold. But the policy allows that you examine an area, a place like Rwenzori, which has very difficult terrain. Sometimes you find where the parish is located, to access a health center 3, it is just an insurmountable challenge.
Yeah, that's true.
So consideration will be made for such a special areas that they can still get a health center 2 or a form of health service, because accessing services at the Gomborora sub-county level can be a challenge. At times you reach an area and imagine if a woman who is pregnant goes into labor at midnight in some of those mountainous areas, how does she reach the health center 3 to get a midwife or clinical services there? So those challenging, hard to reach areas have to be given special consideration, and we shall do that. So areas like Rwenzori, areas like Chigezi, areas like Erigon, they have their own special circumstances, and they have to be considered as such. And I would think as resources become available, even we should increase the wage bill for those districts, those areas, so they can recruit even additional health workers. So that when you have a health center, 3, for instance, they can even do outreaches in those hard to reach communities so that people can get a service.
Well, Honorable, thank you for joining us tonight, and we look forward to hosting you again. Thank you for watching LC Africa, the Content Factory. Until next time, I remain Hassan Tunzi Bwambale.
Kwa Uganda, mulimu ekimere ekyenjawulo era nga kijiddwamu omutindo ogusukkulumye. Engano ya jiko nga ekolebwa ab'amaganjo grain millers. Kola ebyokulya eby'omulembe nga okozesa jiko, owomerwe ne famiri yo ne ku mikolo gyo. Yimusa omutindo gw'enfumba yo, oyimuse essanyu lyo nga okozesa engano ya jiko. Ekolebwa ab'amaganjo grain millers. Engano ya jiko evaamu ebyokulya ebiwooma nga byagalwa, woomerwa akaseera konna nga okozesa engano ya jiko. Maganjo Grain Millers, feeding nations.